Hello everyone, good morning. So, am I live? Can you see me? Can you hear me? Give me a minute to confirm. If I'm live, I will start the session ahead. Okay, give me a minute. Just a second. Okay, yes, I guess it's working. So, very good morning to all of you. I welcome you all for today's session. I am Dr. Priyanka Sachdev here, and today I am here to take an important topic from pathology, from systemic pathology, from GIT, gastrointestinal tract. So many students requested me that I have not covered this topic yet, and they find difficulty in this topic, and this topic is very important for the university exams, second prof, as well as for competitive exams. Many MCQs come from peptic ulcers. So today I am going to teach you peptic ulcer in detail. So shall I continue? So without wasting any further time, let me start peptic ulcers. So if you are a second prof students and going to write your university exam this year, you may get peptic ulcer for your long question. In long question, you have to write at least 5 to 6 pages in your long question. Your long question can be of your 5 marks, 20 marks. Different universities have different pattern. But the thing is that if you're getting any topic in the long question, you have to elaborate it in detail. So peptic ulcer is a topic which usually comes in long question for second prof students. So if it is coming for long question, you have to describe peptic ulcer under following headings. Always try to split your topic into multiple headings. So it will be easy for you to learn that topic, to understand that topic, and for the examiner also it will be easy to check that topic. So first define peptic ulcer, tell me the etiology, tell me the risk factors, how many types of peptic ulcer are there, tell me their sites, tell me the gross, microscopy, complication, investigation, as well as treatment. So in this way we are going to take the peptic ulcer till end. And if you are preparing for your competitive exam, maximum questions are going to come from the various types, site, gross, microscopy and complication. This portion, this will have maximum weightage of MCQs. So let me start. Peptic ulcer, right? So what is a peptic ulcer? Let me first start with the definition. What is a peptic ulcer? We know humans have GIT. The GIT starts from the esophagus. It will continue as stomach, and it will continue as small intestine, large intestine, like this. This is complete gastrointestinal tract. The complete gastrointestinal tract in human is lined by 4 layers. Anything, whether it is esophagus or stomach or intestine. So the first layer, it is mucosa. The first layer is the mucosa. The second layer is the submucosa. Just below the mucosa, we have submucosa having various types of glands and nerves. That is submucosa. Just below the submucosa, there is muscularis propria. It can be circular, longitudinal, the muscularis propria. And the outermost layer is the serosa or adventitia. We all know that, right? Now, to define peptic ulcer, I have drawn the 4 layers. Now, peptic ulcer is a breach. Whenever there is a breach, you know the word breach, let me define. Breach in the mucosa. So I will say breach in the mucosa. When the mucosa is breached, you know breach means break. So there is mucosa, and in between the mucosa is discontinuous. It is known as, this portion is having a ulcer. This portion is ulcer. So that is a definition, pathological definition of ulcer. We all understand what is the ulcer, but we are unable to define it sometimes. So if somebody asks you what is the definition of ulcer, you should say breach in mucosa. The mucosal layer mein there is a break. So there is discontinuity. That portion in which the mucosa is absent, it is known as mucosa. It is known as ulcer. You got my point? So can you define it now? What is a peptic ulcer? So peptic ulcer is the breach in the mucosa of complete alimentary canal, right? So the breach can go deeper. So there is a breach in the mucosa. After that, it can go deeper to the submucosa, to muscularis propria. And if the breach is going through serosa also, it is no more ulcer. It will be known as It is known as perforation, right? So it can start with ulcer. It can go deep, and it can result in the form of a perforation. Yes, Amir, absolutely right. So breach in mucosa is the definition. You got my point. So this is a generalized definition of ulcer anywhere in the body. But currently I am teaching you peptic ulcer. So ulcer is the breach in mucosa. You are absolutely right. But what do you mean by the term peptic? Peptic is that portion of GIT which is exposed to acid. So in human complete GIT, let me draw the GIT again. So in human complete GIT, can you tell me the portion of the GIT which is exposed to acid? only two portions are exposed to acid. Number one, stomach, because stomach secrete acid. In the stomach, there are parietal cells which secrete HCl. So number one is the stomach, which is exposed to the acid, and this acid will be carried to the duodenum, not in complete intestine. In the complete intestine, we know there is alkaline secretion, not acidic secretion, but the stomach secretion, the gastric secretion will be carried forward till duodenum. So duodenum is also exposed to acid. So only two portions in complete GIT are exposed to acid. Number one, stomach, and number one, duodenum. So because of this acid, if there is breach in mucosa, that ulcer is known as peptic ulcer. So ulcer is basically breach in mucosa, but if it is due to acid, the breach is due to, what is the cause of breach? The cause of the breach is due to acid. It is known as peptic ulcer. So basically, I mean to say peptic ulcer can occur at two locations in complete GIT. Number one, stomach. Number two, duodenum. So it is of two types. Stomach one is known as gastric ulcer, and the duodenum one is known as duodenal ulcer. So peptic ulcer are of two types, the gastric ulcer and duodenal ulcer. I guess I am crystal clear in my concept. Both are the peptic ulcer. So basically peptic ulcers are of two types, gastric ulcer, duodenal ulcer. The gastric ulcer occurs in stomach, and the duodenal ulcer of course occurs in duodenum. You may ask me a question, ma'am, why it doesn't occur in ileum, why it doesn't occur in jejunum, in colon, in sigmoid colon, in rectum, why in esophagus? No, nowhere else it occurred, because in the complete GIT only these two portions, that is stomach and duodenum, are exposed to acid, apart from which the complete GIT, rest of the GIT is not exposed to acid. So peptic ulcer cannot occur anywhere else. So that is the thing. You got my point? So you should understand the basic. So read the definition of peptic ulcer now. No need to learn, just understand it. So it is the areas of degeneration and necrosis in the GIT, the areas which are exposed to acid. The areas which are exposed to acid, at that area, if there is a breach in mucosa, it is known as peptic ulcer. I guess you got it, right? So here in this diagram, you can see in the stomach there is a breach, in the duodenum there is a breach. So both the ulcers are peptic ulcer, but one of them is gastric and one of them is duodenal. Say yes, Mukul, Osama, Amir, Abdullah. Yes? Okay. So let me proceed. So let me come on the risk factors. Before the risk factors, I would like to teach you the etiology. Now let me ask you a question. How many of you eat non-vegetarian food, the meat? Many of the humans eat non-vegetarian food, maybe some of you, right? So just suppose this is the stomach and this is the duodenum. Let me draw only two portions of the GIT, the stomach and the duodenum, right? Let me draw the mucosa. This is the mucosal lining. Rough diagram I am drawing to explain your concept, right? This is the mucosal lining, and this is the acid present in the stomach as well as duodenum, right? Now whenever any human being eat a meat piece, it is a meat or non-vegetarian, right? It is a flesh, any animal flesh. So will you be able to digest it? Of course you will be able to digest it. Many humans eat non-veg and they will be able to digest it. Now I want to ask you a question. If the acid present in stomach can degrade this meat piece, why don't this acid degrade own meat? Why don't this acid present in the stomach and duodenum degrade the own flesh, own wall of the stomach and duodenum? It is able to degrade the external meat, external flesh, whatever the non-vegetarian food the person is eating. But if it is able to doing so, why don't the acid present in the stomach and duodenum able to degrade the own flesh, like the wall of the stomach and duodenum? Why don't? Do you know the answer? Yes, Analipsa, you are right. Yes. So it is the mucosal lining is covered by a mucosa, I must say, right? There is a protective covering. So okay, let me draw. So the complete mucosa is lined by a protective covering. There is a protective covering of the bicarbonate, and I must say there is a protective covering. So there are two type of factors. The protective covering is made up of mucus and bicarbonate. So mucosal lining is lined by mucus and bicarbonate. So the acid cannot directly reach to the wall of the stomach. In between there is a protector, there is a barrier, you can say. The barrier is made by this layer. You got my point? Mucus and bicarbonate. So of course it is a protective factor. The acid present in the stomach, it is a damaging factor. It can damage the wall of the stomach, the wall of the duodenum. The pepsin, what is pepsin? Pepsin is an enzyme. We know pepsin is an enzyme that can degrade the protein. Of course. So the wall of the stomach is made up of protein. So you should ask me a question, ma'am, why don't this pepsin degrade own protein, the wall protein? Why? Because there is a barrier in between, right? So acid, pepsin, the person who smoke, the person who drink alcohol, the painkillers. You know, have you heard the term that if we take too much painkiller, there will be acid, there will be ulcer in the stomach? Have you heard it? अगर painkiller बहुत ज़्यादा खाया तो ulcer हो जाएगा. Laymen also know this, right? So the NSAIDs are the painkillers because they increase the acid secretion. You got my point? There is a bacteria, H. pylori, right? So all these are the damaging factors. And so God has given damaging factors also, but on the contrary, God has given protective factors also. In the protective factor, the biggest protective factor is the barrier, that is mucus and bicarbonate layer between the acid and the wall. There is a barrier. There is a barrier apart from which mucosal blood flow, prostaglandins are protective. You got my point? So basically, I mean to say there is a balance between the two. There is a balance between the two, between the damaging factor, between the protective factor. We all have balance. So I guess I don't have peptic ulcer. Most of you also don't have peptic ulcer. Maybe some of you may have. Anyways, so most of the healthy humans which don't have peptic ulcer, they have a balance between the damaging factor and the protective factor. So basically, I want to say inside my stomach and duodenum, I'm having all these. I'm having most of them. Not, I don't smoke, I don't drink alcohol, I don't take NSAIDs very frequently, but yeah, most of the things are present in our human stomach, right? And but we also have protective factor at the same time. So they balance each other, they cancel each other. That's why we don't have ulcer. That's why the answer is that our own acid, our own pepsin do not degrade our own wall. That is the answer. Give me a thumbs up if you got it. So basically there is a balance. Now imagine a human being in which imbalance occurs. By imbalance I mean two things. Listen, either the damaging factor increase, any of the damaging factor, or the protective factor decrease, any of them. But if I say now peptic ulcer, you always have a feeling that it is due to increased acid. It can be due to increased acid, it can be due to increased pepsin, it can be due to increased smoking, increased alcohol. The person who smoke and who drink too much of alcohol, who smoke too much, they always have ulcers. Most of them have ulcers in their duodenum and stomach, peptic ulcers. The persons who take too much painkillers, they have ulcers. The person who have bacteria, H. pylori in their GIT tract, they can have ulcers. You got my point? And in the protective factors, it's mucosa, bicarbonate, prostaglandins, right? These are the protective factors. So either this decrease or they increase. So there is an imbalance between the two. You can see either that. So there is a, in the balance, they should be equal. But if the aggressive factor are heavy, they are more, and the defensive factor are lighter, they are light means they are less. So there is an imbalance. It is known as imbalance and it leads to peptic ulcer. So what is the etiology? You must say, ma'am, there is an imbalance between what? Between the two things, between the damaging factor and between the defense factor. If there is an imbalance, it leads to ulcer. Give me a thumbs up if you got it. So Annalipsa, Amir, everyone got it? Osama, what about you? Got it? So that is the etiology. So I told you the definition, I told you the etiology. In etiology, learn only one word. Imbalance between the two things. What two things? The protective factor, the damaging factor. You must be able to enumerate what are the protective factor. You must be able to enumerate what are the damaging factor. If there is an imbalance between the two, it leads to peptic ulcer. Now in imbalance, you have to increase one and decrease one. In balance, both are equal. So you have to increase the damaging one and you have to decrease the protective one. Either of them will work or both together also will work, right? That can lead to peptic ulcer. Now coming on the risk factors. So you can say, ma'am, when does it happen? Tell me the condition when this imbalance occur. When this imbalance occur. So whenever we have too much psychological stress, now just suppose I am having exams, I am reading 24 hours, most of the time I am reading, studying, or I am having some other family stress, personal stress, right? So in stress, basically the acid secretion increases in the stomach. Stress increases the acid secretion and that can lead to increase in damaging factor, right? That can lead to imbalance. So the person who have type A personality, some persons have type A personality who are always stressful. They take too much stress, right? So they mostly have ulcers in their GIT tract. You got my point? So psychological stress can be one of the reason. The second reason is the physiological stress. It is not psychological stress from the mind. Physiological stress is stress on the body due to some other factors, like the person is going in shock due to cardiogenic shock or hemorrhagic shock, whatever. So body is not getting blood, so the all organs will be under stress. That stress is not psychological, that is physiological, right? Severe trauma, septicemia, right? In extensive burns, you know, in burns is the most painful condition in the world. You know, in burns severe pain is there. Sometimes we have a small pain, a small burn in our fingers or somewhere else in the body, so that is a small burn. But sometimes person have complete burn over the body, right? So in burns, basically due to pain, what happens now, the vagal secretion increases. It causes vagus stimulation. Pain causes vagus stimulation and vagus increases the acid. That's why in burns ulcer always occur. Peptic ulcer always occur. So such a peptic ulcer which occurs due to burns is known as curling ulcer. It is a very important MCQ in all competitive exam, repeated multiple times, right? So burns lead to ulcer, peptic ulcer. The reason, because of the burns, severe pain, and pain leads to vagus stimulation, and because of the vagus, more acid, more damage, and that lead to peptic ulcer known as curling ulcer, right? Now whenever there is an intracranial lesion in the brain, any tumor, any space occupying lesion, that also increases the vagal stimulation. In the brain. It stimulates the vagus center in the brain, and that also increases the acid. So intracranial lesions also have peptic ulcer. So such a peptic ulcer which results due to intracranial lesion is known as Cushing ulcer. Now both of them are starting from C. This is curling, this is Cushing. That's why both are important MCQ. In the option you will get both, but students sometimes get confused. You got my point? So what I am saying, the burns also lead to ulcer, and intracranial lesion also lead to ulcers, right? So the ulcer due to burns is known as curling, and the ulcer due to intracranial lesion is known as Cushing. Both are peptic ulcers only. Both are the type of peptic ulcer. The reason for both of them is same, the vagal stimulation. More vagal stimulation, more acid, more ulcer. Give me a thumbs up. Come on, everyone. So these are two important MCQs. Those who are preparing for competitive exam, this MCQ repeated many times in your exams. Whatever exam you ask, give me a thumbs up. Come on. So curling and Cushing. I guess you got it, right? So these are the risk factors. The person who take too much of the drug. In the drugs, I mean basically steroids or NSAIDs. They also have ulcers. More tendency to have ulcers because of the increased acid secretion. The person who drinks too much of coffee, the person who drink too much of alcohol, or the person who smoke too much, they also increase acid secretion because they act as an irritant in the gastric mucosa. So I'm a coffee lover, so I drink 2-3 cups of coffee in a day, right? So if you drink too much of coffee, now 2-3 cups is not too much, but yeah, if you drink too much of coffee, it irritates the gastric mucosa, it stimulates the parietal cell, so more acid secretion, and more acid secretion leads to ulcer, right? So that is the risk factors. I guess till now we have covered 3 things: the definition of the peptic ulcer, the etiology of the peptic ulcer, and the risk factors of the peptic ulcer. I guess you all know the 3 answers. Yes. What's the definition? The breach in the mucosa. It is a breach in mucosa. Which mucosa? The mucosa which is exposed to acid. So the breach in the mucosa is known as peptic ulcer. Etiology, the word imbalance between the 2 things. You know the 2 things, the damaging factor, the aggressive and defense factor. You can enumerate them. And risk factors, there are multiple, you can enumerate them, right? So let me come on the types now. The next heading is the types. How many types of peptic ulcer you know? There are 2 types of peptic ulcer. I have already taught you. This is the first classification. If the peptic ulcer occur in stomach, it is known as gastric ulcer. If it is occurring in duodenum, it is known as duodenal ulcer. So I have already taught you that this is the human GIT. It is the stomach and duodenum. I am drawing only this portion, right? So acid is present here in the stomach, and same acid goes in the duodenum. After duodenum, this acid gets neutralized by the alkaline intestinal secretion. So after duodenum, we have jejunum and ileum, but jejunum and ileum don't have acid exposure because it is already neutralized. So acid is present only at 2 portions, the stomach and the duodenum. That's why this ulcer, the peptic ulcer, can occur in stomach, can occur in duodenum. If it occurs in stomach, gastric ulcer. If it occurs in duodenum, duodenal ulcer. Both are peptic ulcer because both are due to acid. Acid oversecretion. Give me a thumbs up, right? So it is of two types, the gastric one, the duodenal one. This is first classification. The second classification, whether the ulcer is benign or malignant. 1% ulcers are malignant, 99% are benign, right? So you can classify like this also, right? But the main classification, if someone is asking, you must go with this classification. If you are not telling this classification, it's okay. It's okay. But you must know 1% out of them is malignant. It turns malignant, right? But 99% are benign. I guess it's clear to you, right? Here you can say this is gastric, this is duodenal. Both are peptic ulcer. Both are peptic ulcer. You can clearly see them, right? Now, you tell me, okay, you know this is stomach. Let me draw a small portion of the stomach. This is a stomach, right? And after this is the duodenum. You know this portion of the stomach is known as lesser curvature. You know that. And this portion of the stomach is known as greater curvature. You know that. Those who don't know, they must learn. So lesser curvature, greater curvature. You know this, right? Now this portion of the stomach is known as the junction of the esophagus and the stomach is known as fundus. This is known as fundus. This portion, this bulge is known as cardia. Cardia. So there is cardia, there is fundus. This is main body. This is main body. This portion, the end portion, is pylorus. And this canal, the junction of the stomach and the duodenum, is known as antrum. So basically stomach have 5 portions: fundus, the junction of the esophagus and stomach, then cardia, then body, then pylorus, then antrum. So basically there are 5 portions, right? So this is the classification. You can see the various portions inside the stomach. Let's talk about the duodenum. Duodenum have 3 portions: first, second, third. You already know, you have learned all this in anatomy, I guess. Now I want to ask you a question. I told you there is gastric ulcer occurs in stomach, duodenal ulcer occurs in duodenum. Both are the type of peptic ulcer. You tell me, gastric ulcer occurs in which portion of the stomach? Is it more common on the lesser curvature or is it more common on greater curvature? The first question. Whatever you are saying, is it in fundus, cardia, body, pylorus or antrum? Where it is? So first tell me in the stomach where it is. Number 1, the site, the exact site. The same question for the duodenum. First part, second part, third part. Right? In the duodenum also. In the duodenum also, first, second, third part on the anterior wall or posterior wall or medial wall or lateral wall. Which wall? So tell me the exact site. The site is really very important for your MCQs in your exam. So let's talk about them one by one. You got the question, I guess. Yes, I'm telling you the answer. Yes, yes. Most of you are right. Let me tell you the answer. Let's first talk about the duodenal ulcer. In the duodenal ulcer, it occurs in the first part of the duodenum, not in second, not in third. Common sense. Maximum acid exposure, which part of the duodenum? First, second or third. So acid is coming from the stomach. You can imagine. So acid, a bolus of acid is coming from the stomach. So in the stomach, when it is entering the duodenum, so first part of the duodenum is maximum exposed to the acid. In the second and third part, most of the acid is neutralized. So they are less exposed. So which portion is most exposed? First part of the duodenum. Now you will never forget. So first part of the duodenum have maximum duodenal ulcer, right? It is just behind the post-pyloric canal, just after, when the stomach is ending and duodenum is starting now, at that starting point, because that is the maximum exposed area and it is on the anterior wall. So learn, it is the first part of the duodenum and anterior wall. Learn that. So that is about the duodenum. I guess everyone got it. Yes, Amir, good. Yes. Now coming on the gastric ulcer, most of you are right. Yes, Osama, Annalipsa, Aquira, everyone is right. In the gastric ulcer, it is on the lesser curvature. You all are right. Not on greater curvature, it is on lesser curvature. In the lesser curvature also, it is in the pyloric antral canal. It is not in body, it is not in fundus, it is not in cardia. It is in the end portion, pyloric antral. And here it is more common on the posterior wall of the stomach, not on anterior wall. You got my point? You got my point. So that is the most common site of the ulcers. Right. Now overall, can you tell me which is more common, duodenal or gastric, out of the two? Both are peptic ulcer, but which are more common? So of course duodenal are more common and gastric are second most common. So let me summarize in a diagram. I will summarize everything in a diagram and I guess you all will help me for that. So let me draw a stomach and let me draw a duodenum. Right. Now you tell me in the stomach what is the most common site, lesser or greater? Lesser curvature. In the lesser curvature also, it's in the pyloric antral canal. So this is the most common site of gastric ulcer. It is on the lesser curvature, you all can see, and in the lesser curvature, it is on the end portion, that is pyloric antral canal. Give me a thumbs up. Give me a thumbs up. In the end, it is, so this is gastric ulcer, and it occurs on the posterior wall. Here on the posterior wall, not on anterior. So gastric ulcer, let me summarize. Gastric ulcer on the posterior wall, gastric ulcer on the lesser curvature, and gastric ulcer on the pyloric antrum. Pyloric antrum portion, not in body, not in fundus, not in cardia. So that is the summary, the three things you have to learn about the gastric ulcer. On the lesser curvature, pyloric antral canal, and posterior wall. That's it, right? Coming on the duodenal ulcer. Where is duodenal ulcer? First part or second part or third part? It occurs in the first part, immediately after the ending of the stomach. The portion where stomach is ending, duodenum is starting at that point, right? So this is your duodenal ulcer. So duodenal ulcer, again learn two things. Number one, it occurs in the first part, not in second, not in third. The first part of the duodenum, number one, the first part, and second, it occurs in the anterior wall, not in posterior wall. So learn first part and anterior wall. So this is the summary. Now after that, which is more common? Duodenal is more common or gastric is more common out of the two? So duodenal is 4 times more common, 4 times more common as compared to gastric. If gastric is X, duodenal is 4X. You got my point? So everyone give me a thumbs up, right? So that is the site. You can't imagine how many MCQs come from this page. You have to learn which is more common. Uske baad, individually what is the best site? Individually what is the best wall, maximum chances where it occurs. So gastric, duodenal, this is the summary. I guess everyone got it. Give me a thumbs up. So that is about the site. Here also same diagram is drawn. So you can see this is the site of the gastric ulcer, most common, and this is the site of the duodenal ulcer, most common. So first and second. After that, third, fourth, fifth are also there. The third site is the gastroesophageal junction, that is in the cardia. So this is the first most common in the duodenum. This is the second most common in the stomach. This is the third most common site, that is in the cardia, gastroesophageal junction. The fourth most common site is this one. In some individuals, we do gastrojejunostomy, in which the duodenum and ileum is cut, and stomach is already combined with the jejunum. You know, so you know the sequence now. So here stomach is binded you can see with the jejunum. So this is the in that individual, this is the fourth most common site, and the fifth one is Meckel's diverticulum. So you know the 5 most common site. This is the fourth one and this is the fifth one. If you can't learn all 5, it's okay. Learn the first 2. The first 2 are most important. Most common site and second most common site. Can you enumerate? Can you help me? So first most common site, second most common site, third most common site, fourth and fifth. Can you help me? We will try together. Don't worry. I'm talking about everything about peptic ulcer. So most common site of the peptic ulcer. So you will say, ma'am, first most common site inside the duodenum. In the duodenum, describe the first part of the duodenum, not in second, not in third, and in the anterior wall. That's the first most common site. Second, inside the stomach. Stomach means gastric. In the stomach, describe it on the lesser curvature, in the pyloric antrum, and on the posterior wall. So that is the description given for the stomach. The third most common site, again in the stomach, but on the cardia, in the cardia of the stomach. That is the junction of the esophagus and stomach, right? The fourth most common site is gastrojejunostomy, and the fifth is Meckel's diverticulum. You can learn like that, right? Now question mostly asked on the first and second. That's it. You got it? Yes, absolutely right, Amir, Osama, very good. Shall I move ahead? Shall I move to the next heading? So you can see first, second, third, everything is visible. So let me tell you the differences. I will come on the differences between duodenum and gastric later on. Let me tell you the grossly, how does the ulcer look? Tell me the gross. So you can see grossly we cannot differentiate this is a gastric ulcer and this is a duodenal ulcer, but we can differentiate it is a benign ulcer and it is a malignant ulcer. I told you 1% ulcers are malignant and 99% are benign. So looking at them grossly, you can say which is benign and which is malignant. Roughly you can give a guess, right? Look at the margin of the ulcer. You can see ulcer is the breach in mucosa. So this portion, the big pink color portion, this I'm marking with red, right? This portion don't have mucosa. That's why it is an ulcer. The mucosa is lacking. Now don't look at the ulcer. Look at the margin of the ulcer. That will decide. So if the margin is punched out, you can feel with your finger, it is coming out. The margin is bulging out, punching out. You can feel the sharp margins. So it is a benign ulcer. But if the margins are rolled out, can you see the margin here? They are not sharp. If you touch your finger now, they are rolled. They are circular. They are not sharp. So it is a malignant ulcer. So just touching the margin, you can give a guess. The margin are sharp, punched out, it is benign. The margin are rolled out, circular, it is malignant. Give me a thumbs up. So that is the thing. So looking at the margin, yes. Looking at the margin, you can say whether it is a benign or malignant. Coming on the microscopy, if I cut this portion or this portion, whatever, and make a slide, histopathological slide. So how does it look? It looks like this. It looks like this. Can you see? You will say, ma'am, what is it? What is it? Is it stomach or duodenum? It can be anything. I cannot say. Whatever it is. Both have 4 layers. The mucosa, submucosa, musculus propria and serosa. So let me draw the 4 layers here. Can you see? This is mucosa. So mucosa is continued and discontinued here. And again here it is continued. So here I can say this portion is a ulcer. Can you also say a breach in mucosa? So this portion is ulcer because there is a breach in mucosa. Beautiful diagram. You can see mucosa this side, but in between the mucosa is lacking. So that portion is an ulcer. Give me a thumbs up. So see this ulcer. So in the ulcer, now you can see the mucosa. After that you can see this is submucosa layer. Behind that this is submucosa. So ulcer is going deep in the submucosa and this is muscularis propria. So ulcer is going deep in the muscularis propria also. Right. So it is a deep ulcer. It can be superficial, it can be deep. Now look at the ulcer only. Don't look sideways. Look at the ulcer. In the ulcer we can divide the ulcer into 4 zones. Can you see the uppermost zone? Let me show you. I'm talking about this, the pink color zone. The uppermost zone. You can zoom out if you can. This zone is necrosis. That's why it's pink. It is known as necrotic zone. So the uppermost zone is necrosis. That's why known as necrotic zone. Give me a thumbs up. The first zone. Just below the necrotic zone, what you are seeing? The next zone, what you are seeing? Can you see this zone? Inside this zone, you can see some cells. If you see the cells, some of them are neutrophils, multilobated nucleus, and some of them are lymphocytes. So I can see abundant WBCs in the zone. WBCs, the neutrophils, the lymphocytes. So basically inflammation is there. So the second zone, this zone is known as exudative zone. Superficial exudative means inflammation. So the first zone, outermost, is the necrotic. Just below the necrotic there is inflammation. So that is known as superficial exudative zone, right? The third zone, go deeper, go more deeper, see what is happening. See this zone, the third zone. Can you see? Inside this zone, I can see inflammation is there. The neutrophils, lymphocytes are there. But I can see abundant of blood capillaries also. If you can see the blood capillaries. So inflammation with blood capillaries. Inflammation with blood capillaries, this is known as granulation tissue. So granulation tissue is formed. Healing is taking place. So this zone is known as granulation zone. So necrotic zone, exudative zone, granulation zone, and the last zone, the fourth zone, you can see the fibrosis here. Fibrosis and pathology is known as cicatrization. So the last zone is the cicatrization. Give me a thumbs up, everyone. So these are the 4 zones of the ulcer. Can you understand? The outermost is the necrotic, then superficial exudative, then granulation tissue, and then cicatrization. So if you want to draw, you are a second prop student, so draw the mucosa, and in between the mucosa should be discontinuous, right? So the discontinuous portion will be the ulcer, right? In that discontinuous portion, you have to draw 4 things. The outermost is the necrosis. Draw the necrotic tissue. After that, try to draw the inflammation. So all these are WBCs. Some of them are neutrophils, some of them are lymphocytes. So that is exudative zone. After that, along with few WBCs, you draw the blood capillaries, multiple blood. So this is granulation tissue. And the last one, the last zone will be the fibrosis, that is cicatrization. So these are the 4 zones of ulcer. Everyone give me a thumbs up. So these are the 4 zones of ulcer. Now let me differentiate the duodenal ulcer and gastric ulcer. As I have told you, duodenal is 4 times more common as compared to gastric. First learn that. Duodenal is 4 times more common than gastric. So let me write duodenal ulcer. Let me write this is gastric ulcer. Now listen, if any patient is coming to your clinic and patient is complaining that, doctor, I am having pain in my epigastric region here, somewhat in my stomach, a vague pain, and it increases with food, it decreases with food, it is associated with food basically. So you are suspecting an ulcer. Now the best thing is to do an endoscopy to differentiate whether the ulcer is present in stomach or duodenum, whether it is a gastric ulcer or duodenal ulcer. So to confirm, you have to do an endoscopy. You know, in the endoscope there is a camera that will look after and exactly tell you what type of ulcer it is. But before doing endoscopy, clinically how you can differentiate? Can you differentiate, is it duodenal or gastric? Yes. So clinically, based on these 9 points, you can differentiate. So you have to ask 9 questions to your patient, right? 9 questions based on which You will give a rough idea. It is not confirmed. Confirmation will done only on endoscopy, please understand. But you can have a rough guess in your mind, where is the ulcer? Is it in stomach or in duodenum? So first ask, the first question you should ask your patient, with food, your pain increase or decrease? If you eat food, your pain increase or decrease? If the patient say on eating food the pain decrease, it is duodenal ulcer. And on eating food, the pain increase, it is gastric ulcer. Give me a thumbs up. Give me a thumbs up on this point. So the first thing you should ask is the food, the association of the food. If on eating food pain increase, it is stomach, and pain decrease, it is duodenum. Give me a thumbs up. Yes, you got it. So first thing is the food. The second question you should ask your patient, whether you have night pain, yes or no. You have pain during the day, but sometimes it happens in the night. You already sleep, you are gone to your bed, you are in sleep, and from the sleep you just wake up due to severe pain. It happens sometimes. So if the patient is saying yes, night pain is very common, sometimes I woke up at 3 a.m. at night, 4 a.m. at night, just because of severe pain, right? So it is more common in duodenal ulcer, but less common, no night pain in gastric ulcer. If the patient is saying no, I never have night pain, means I am having pain, I just go to sleep and directly wake up in the morning. Due to pain, I don't get up in between night. So that is going to be gastric ulcer. So second question is night pain. So association with food, association with night pain. You want to understand the meaning of these, why it happens. Okay, I will explain you why food decreases in gastric duodenal ulcer and night pain are more common in duodenal. The opposite happens in gastric. You should have a valid explanation of everything. If you don't have, you should ask me why it is like this. The reason is having, everything have a reason. You should know the reason. So this is the stomach, this is the duodenum, right? Now listen, either the ulcer is in the stomach or the ulcer is in the duodenum, right? Now let me talk about food first. Let me first explain the food. If the person is eating food, so when the food reaches in the stomach, it causes more acid secretion. It causes more acid, it will cause more pain, right? That's why food increases the pain in gastric ulcer. You got my point? But whenever we have food in the stomach, you have learned this in physiology, the intestine also starts secreting alkaline secretion. In the stomach, we have acidic secretion. In the intestine, we have alkaline secretion. When food we chew now, both things start secreting. Stomach secrete acid, intestine secrete alkaline secretion. Both are getting prepared for the food, right? That food is about to come. So whenever we have food in the mouth, the stomach does acidic secretion and duodenum does alkaline secretion. So whenever food reaches the stomach, there is more acid in the stomach and there is more alkaline in the duodenum. So that's why acid increases pain and alkaline neutralizes the acid, so it decreases pain. That's why on eating food, the pain in the stomach ulcer increases and the pain in duodenal ulcer decreases. I hope I tried at least. At least I tried. You got it? You say yes or no. I tried at least. If you understand it, it's okay. If you don't understand, you just learn. Give me a thumbs up. Come on. You got the point. So why food have different association? Food increases pain in gastric ulcer and food decreases pain in duodenal ulcer. The reason is the acidic secretion and alkaline secretion. Whenever there is a food in the mouth, I'm chewing something like this, right? So I'm having secretion both ways. In the stomach, I'm having acidic secretion, and in the duodenum is intestine, I'm having alkaline secretion, right? So acid increases pain, alkali neutralizes the acid and it decreases pain. So this is the reason. I guess I tried, right? So this is the reason for the food. Let me try the reason for the night pain. Let me try the same concept. I will try with the same concept. Let me try. I never learned the things, you know. I just try to explain them in front of you only. I'm not prepared to explain you this, right? Anyways, so can you see? Again, let me draw the two ulcers. So this is a stomach gastric ulcer and this is a duodenal ulcer. So in night, when we have the last food in the night, the last food we have our dinner either at 9 p.m., 10 p.m., whatever. So usual people eat at this time, not about you, right? You eat at 1, 2, whatever. So usual people take their dinner at night and after that they don't take anything and they just go to sleep for the next 8 hours. For the next 8 hours, 7, 8 hours, they just go to sleep. So for the next 8 hours, people don't take food, right? But you have heard the word basal acid secretion. Whether we eat or do not eat, a small amount of acid is always secreted in the stomach. Have you heard about it? Say yes if you have heard about it. Yes. So we don't eat for the 8 hours, but for that 8 hours, the acid is going to be secreted here. The acid is going to be a small amount of acid secreted here, and whatever acid is secreted goes and accumulates in the duodenum. in the duodenum. That's why night pain are more common in the duodenum, but not in gastric. You got my point? So this is the reason given in the books, right? So you should learn it. You should learn it. The food, the night pain. After that, vomiting and melena and hematemesis, right? Three things I am going to explain. So again, I have to draw the same diagram again and again to explain you three concepts now. You will tell me vomiting is more common in which ulcer? I'm having two ulcers, one in stomach, one in duodenum. Gastric ulcer, duodenal ulcer. I'm asking about vomiting. Who will tell me? Common sense. Vomiting is common in which ulcer? Vomiting. So vomiting is more common in gastric ulcer. When the person eat the food, it will come out because person have pain while eating food. So he will vomit out. So vomiting is more common in gastric ulcer, not in duodenal ulcer. Yes, common sense, right? Now let me explain you the next two terms. The next two terms, one is hematemesis, and one is melena. What do you mean by the terms? Hematemesis means blood in vomiting. Blood in vomit is known as hematemesis, and blood in stools, blood in feces, blood in stools is known as melena. So the ulcer bleed. We all know all ulcers bleed. This ulcer also bleed. This ulcer also bleed. So if the gastric ulcer bleed, the blood will come more commonly in the vomiting. So gastric ulcer results in hematemesis, right? That is blood in vomiting. But duodenal ulcer, blood will go in the stools. That's why duodenal ulcer present with melena. So patient will complain you, I am having brown color vomiting or I am having red or brown color stool. So that will matter. The blood is coming in the vomiting or in stool. You have to ask the patient, or patient will complain by themselves. You don't have to ask them. They will say, doctor, I am having red color vomiting, brown color vomiting. Doctor, I am having red color stools, right? I think it is blood. So this blood is in vomit or the blood is in stool. That is the patient present with hematemesis or melena. That matters. You got my point? Give me a thumbs up if you got it. So here vomiting is not very common. In gastric ulcer it is common. In gastric ulcer, hematemesis is common, but in duodenal ulcer, melena is common. I want thumbs up from everyone. You got the meaning of hematemesis and melena? Hematemesis is blood in vomiting, common in gastric ulcer, and melena is blood in stool, common in duodenal ulcer. Give me a thumbs up. All ulcer bleed, but blood is going where? In the vomiting or in stool. So that matters, right? That will help you in thinking what type of ulcer it is, right? Now you tell me, what was the association of food? Just revise it once again. Food increases pain in gastric ulcer. So patient will leave eating food. He will eat very less food. He will not eat much because he knows whenever he eat, he don't have good experience. He have pain. So he will stop eating. He will eat very less food. So he will have significant weight loss. So gastric ulcer patient will complain you, I am having weight loss 3-4 kg in last 2-3 months. Right? Significant weight loss. But duodenal ulcer, on eating food, the pain decreases. So whenever he had pain, he eat, whether he is hungry or not. Whenever he had pain, he will eat. So he will eat more, right? Not less. So he don't have any weight loss. You got my point? So that is about the weight loss. If you understand the concept, you don't have to learn even a single point, I must say. You just understand it, right? In the MCQ, you can do it properly. In the exams, you can write it properly. Yes, Osama, absolutely right. Right now, in the gastric ulcer, when we eat spicy food, we have more acid secretion. You already know that. If you eat chilies, red chili, green chili, spicy food, you have more acid. But if you eat bland food without spices, you have less acid secretion. We all experience it now. Sometimes we eat the spicy food, the Chinese food, spicy food, the pani puri, we have more acidity, more acid secretion. We can feel that. So here, since patient have pain, and in gastric ulcer pain increases with acidity, so patient chooses bland diet. Patient will say, I will not eat spices, I will not eat fried food, not curries, not anything, because whenever I eat this food I have pain. So patient chooses bland diet. But duodenal ulcer will eat everything, because on eating his pain is decreasing. He don't have any particular choice, he eat everything. So you should ask the patient, what is your choice of food? You eat only bland food or you eat everything? So that also make you a broad judgment that what type of ulcer patient is having. Ultimate is endoscopy, but you have to ask all these questions: whether food increases your pain or decreases your pain, whether you have night pain, yes or no, whether you have vomiting, yes or no, whether you have blood in stool, yes or no, whether you have blood in vomiting, yes or no, whether you have loss of weight in the last few months, yes or no, whether you have peculiar choice of food, the bland food or spicy food, yes or no. So based on that, you can decide. Give me a thumbs up if you are getting my point. So you are asking all these questions to your patient to find out which type of ulcer your patient is having basically. Right, now we know we know the abdomen is divided into 9 quadrants. Have you heard about the 9 quadrants in physiology? Say yes. You all have heard. So we divide. So this is our thoracic cavity. This is abdominal cavity. I'm talking about abdominal cavity. I guess you all know how to divide the abdomen into 9 quadrants. You can learn about the 9 quadrants. You have learned. So where is the stomach and where is the duodenum? So let me draw the GID. It's the esophagus. This is the stomach in the center, and the duodenum is towards a little bit right. This is right of the patient, this is left of the patient. I guess you can understand the patient is standing in front of us, right? This is duodenum, right? Now you tell me where is stomach. Gastric ulcer will give pain in which quadrant? So gastric ulcer will give pain here in the central quadrant. This is epigastric quadrant, and duodenal ulcer will give pain in this quadrant. So the quadrant is different. You should ask the patient to lie down on your examination table, and you just examine with your fingers. You just palpate. You see where is the patient have tenderness. You ask in this quadrant, in this. So in one of the quadrant, patient will shout, yes, yes, doctor, I am having pain in this quadrant. So based on the quadrant, you can differentiate. You can see the quadrant is different. What is the different quadrant? Can I remove this image? You got it? Give me a thumbs up. You got it? Say. So in case of gastric ulcer, the quadrant is midline, the central quadrant in the epigastrium. The central quadrant I have shown you. And in case of duodenal, it is right hypochondrium quadrant. So out of the 9 quadrants, which quadrant have pain? That also will define what type of ulcer the patient is having. Give me a thumbs up. So that is the next point. The next point, ask the patient, do you have seasonal variation? More pain during winters, less during summers. Seasonal variation is more marked in duodenal, but no seasonal variation in gastric. The reason is not known. The reason is not known. And the next point is, see what class of patient, what is the occupation of the patient. The patient is having such occupation which is having more psychological stress. The patient is working in some private company or some student who is having more psychological stress. So duodenal ulcers are more common. If the patient is labor group matlab who take more weight, not psychological, physical stress is more. So that patients have more gastric ulcer. So based on these 9 criteria, you can decide whether it is a gastric ulcer or duodenal ulcer. You have to ask 9 questions to your patient along with the examination. So first thing, you have to ask about the food, increase pain or decrease pain. The second, you have to ask about the night pain, yes or no, right? The third, you have to ask about the weight loss. The fourth, you have to ask about the choice of food, right? The next, you have to see the quadrant in which it is having. Next, you have to see the occupation. Maybe I'm missing some point, but you have understood everything. Give me a thumbs up, everyone. So Zamir, Amir, Analipsa, Osama, everyone, give me a thumbs up. So based on that, you can decide, and you can't imagine how many MCQs come on this page. Many MCQs. So if you have understood everything, let me just skip the theory. You can see everything I have explained you. So just a second. Pain we have already understood. The gastric ulcer, epigastric pain is there, and it occurs within 2 hours after food, right? It never occurs at night. But in duodenal ulcer, pain is more severe, occurs late night. It is known as hunger pain. Patient is hungry since last 8 hours. Since last 8 hours, patient is not eating anything during the night. That's why patient have pain. The pain is different, right? After that, vomiting. Vomiting is more common in gastric ulcer. It is less common in duodenal ulcer, right? After that, we have understood hematemesis and melena. Hematemesis and melena both occurs in gastric and duodenal, but hematemesis is more common in gastric and melena is more common in duodenal. You understood the ratio, right? So that's how weight loss is more common in gastric, but no weight loss in the duodenal. You know the reason. You have to see the tenderness in which quadrant. So the gastric ulcer have midline tenderness in the epigastrium, and duodenal ulcer have right hypochondrial tenderness. So you can understand. So we are done with the clinical features and the differences also. Till now, we have learned the definition of peptic ulcer. You know the etiology of gastric ulcer. You know the risk factors of gastric ulcer. You know the types of the gastric ulcer. You know the gross, based on gross, how to see the margins and classify whether it is benign or malignant, right? You know the microscopy. In the microscopy, there are 4 zones. You know the 4 zones, upper to lower, you know the 4 zones. After that, you know the clinical features, how to differentiate based on 9 clinical features. The gastric ulcer and duodenal ulcer. The next is the complications. The next topic is the complication. Give me a thumbs up. Come on, everyone with me till now. Do you have any doubt? Can I go ahead? The complications of gastric ulcer. So coming on the complications of the gastric ulcer. What's the most common complication you think? The most common complication is bleeding. The ulcer bleed. The bleeding from the ulcer. Bleeding or hemorrhage. It is the most common complication of both ulcers. The gastric ulcer, the duodenal ulcer. Right? More common bleeding occurs in duodenal ulcer from the posterior wall. Right? And it leads to iron deficiency anemia. So if you do the CBC of the patient, hemoglobin is less. Right? In ulcer patient, hemoglobin is less. Common sense, they are bleeding, they are losing the blood, right? That's why their hemoglobin is less and they have iron deficiency anemia, right? Now either the lost blood will come in the vomiting or the lost blood will come in the stool, depending it is gastric ulcer or duodenal. So either the vomiting will be coffee ground color or the stool will be red color, right? So the lost blood will go somewhere, it will not remain there only. So if the blood is coming in the stomach or the duodenum, either it will be lost in the vomiting or it will be lost in the stools. You got my point? Give me a thumbs up. And the patient have iron deficiency anemia. But the point you have to learn here for MCQ, duodenal ulcer bleed more commonly. That is about the bleeding. And bleeding is the most common complication, right? So tell me the name of the artery which bleed in both the ulcer. So in duodenal ulcer, the name of the artery which rupture and bleed, it is gastroduodenal artery, right? And the name of the artery in gastric ulcer which rupture and start bleeding in ulcer, it is left gastric artery. Both are MCQs. More important for MCQs, not for theory. But you should know for theory also, right? You got it? You got it? So name the artery. Gastroduodenal artery for the duodenal ulcer and left gastric artery for the gastric ulcer. You can learn like that. So that is about the artery. The second complication is perfo. You know what is perfo? So there are 4 layers as I have told you. This is the first layer, mucosa. Then we have submucosa having glands and nerves. Then we have muscularis propria. And the last outermost layer is the serosa. We have 4 layers. What is the ulcer? A breach in mucosa. So ulcers start from here. Ulcers start from here. It can go deeper, 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 involving the second layer, third layer. But when the 4th layer is also involved, so it is a perfo. It is a perfo. Perfo means a hole. You know, a hole is happening. So that is a perfo, right? It is an emergency situation. It is the second most complication. When the ulcer becomes deeper, 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 patient is not taking any treatment. So it is going deeper, deeper, deeper. Patient is not worried, right? Not taking treatment. It is the most common cause of death in peptic ulcer. If perfo is occurring, it is an emergency. Now 50% chance you can save the patient, 50% you can't, depending the availability of the hospital, doctors, everything. Emergency surgery, laparoscopy is required, right? So it is the acute abdominal emergency. Patient has severe pain, patient have high bleeding, patient will collapse, and it is an emergency, right? So again, it is more common in duodenal ulcer in the anterior wall. So both the complications, the bleeding as well as perfo, more common in duodenal ulcer, but bleeding is common from the posterior wall duodenal ulcer and perfo is common in the anterior wall duodenal ulcer. I guess you got it. You can see here is a diagram of the perfo. You can see here the ulcer is deeper, 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 and it is perforated. Give me a thumbs up. The third and the last complication is malignant transformation. Only 1% ulcer convert into cancers, and it occurs only in gastric ulcer, not in duodenal. Duodenal ulcer never turn into malignant. All the duodenal ulcer are benign only. They never turn malignant. But out of the gastric also remain benign. 99% of them are benign, but only 1% turns malignant. So these are the 3 complications. Okay. So let me define the 3 complications. Can any one of you help me in defining the 3 complications? Give me a minute. I can't see your chat. Give me a minute. Let me open it again on the YouTube. I can see now. So can you help me with the 3 complications? Annalipsa, Osama, Amir, Sweetie. Who will help me? What is the most common complication? Yes, the most common complication is bleeding. The second most complication is perforation. And the third complication is malignant transformation. Right? So can you tell me which ulcer have which complication? Duodenal or gastric? Can you tell me that? So bleeding is more common in duodenal ulcer, but posterior wall duodenal ulcer. Perfo is also common in duodenal ulcer, but anterior wall duodenal ulcer. And malignant transformation occurs only in gastric ulcer. Only 1% gastric ulcer. Duodenal ulcer never turn malignant. It is an MCQ. You got my point? So from the bleeding, you must tell me the patient have iron deficiency anemia. Due to bleeding, patient have iron deficiency anemia, number 1. Number 2, patient have either the hematomasis or melena. You can understand the meaning of the hematomasis and melena. Tell me the name of the 2 arteries. So if it is duodenal ulcer, the name of the artery is gastroduodenal artery, and if it is gastric ulcer, the name of the artery is left gastric artery. You should know the artery. So that's all about bleeding. All the MCQs, theory, everything is covered. About perfo, I have already told you it is an emergency. It is an emergency patient present with acute abdomen, and it is more common in duodenal ulcer anterior wall. Right? So coming, yes, Osama, absolutely right. Yes, Padmavati, yes. In the malignant transformation, it occurs only in gastric ulcer. That's to only 1%. 99% are benign. So can I say the two type of the ulcer, duodenal and gastric? Duodenal are 100% benign. They never turn malignant. But gastric are 99% benign. 1% can turn malignant. You can learn it. Please understand it and learn it. Never forget. So you have understood the three type of complication. Now let me tell you two catchy terms for your MCQs, for your theory, for your small question, short questions. Have you heard the term teapot stomach? What do you mean by teapot? You drink tea now in a teapot. So stomach becomes this shape. This is known as teapot. Can you see the shape? Yes, see the shape. So let me tell you, when the stomach, from this shape, stomach convert to this shape. Why? So can you see this shape is teapot? This shape is like a teapot stomach. Sometime in ulcer, the stomach become teapot shape. Let me explain you how. If the ulcer mostly it occurs on lesser curvature, na? So let me draw a stomach for you. Okay, I will try. My drawing is poor, but still I will try. So this is the normal shape of the stomach. You, me, everyone have this shape, right? Imagine someone is having the ulcer on the lesser curvature. The stomach ulcers are more common on lesser curvature. We all know that, right? Now, if this is an ulcer and patient is taking treatment for that ulcer, so what after the treatment we are expecting? After the treatment we are expecting healing. All the treatment leads to healing. Yes or no? Say yes. Treatment leads to healing. What is healing? In the healing, fibrosis takes place. In pathology, you learn, no? Healing means end result is fibrosis. Basically, in the healing, scar is formed. Scar means contracture. There is contracture. So basically this portion undergo contracture. So it will become shortened. You got my point? I guess you are getting my point. So basically lesser curvature becomes small. It is small because of contracture. But the greater curvature is still big. It is still big. So the shape of the stomach is like this. Now you can understand the transformation, I guess. This transformation. It is due to longitudinal shortening of the lesser curvature. Say it again. What I have said? Longitudinal shortening of the lesser curvature due to healing, due to fibrosis, due to scar, due to contracture. Everyone give me a thumbs up. Everyone. So this is known as teapot stomach. Now describe, don't learn. Describe it. It is longitudinal shortening of the lesser curvature of the stomach. So it will become teapot. The reason is the contracture due to healing, right? So see, the stomach is looking like this. It's teapot, right? The teapot stomach. You can understand. I guess you can understand. So it is due to cicatrization. That is fibrosis. Right? So can we go ahead? The next is the hourglass. Hourglass, let me see if I have put the diagram. Have you seen a glass which is used to take wine, a fancy glass? I don't know. I don't take wine, but I have seen this glass. In hotels, everywhere, we have this kind of glass. Have you seen? It is a glass, right? कांच का glass होता है. It is usually used for wine, beer, and we can use it for tea also, but I don't have it at my home. So this glass is known as hourglass. What the shape is known as? This shape. So basically the contracture in the middle and expansion at both ends. This shape is known as hourglass. I forgot to put the diagram. You just Google hourglass. Many glasses will come with this shape, right? So sometimes stomach become hourglass. Can you see? Hourglass shape. So it is looking like a hourglass. Can you see here? It's hourglass. In the radiology also you can say it's hourglass. It's looking like a hourglass. See the contracture in the middle and expansion at both ways. So hourglass is the saddle shaped contracture at the lesser curvature. So let me draw the stomach again to explain you this. So again, where is the ulcer? On the lesser curvature. Okay. Last time I have done the longitudinal contracture. This time I am doing the transverse contracture. I don't know whether I'm able to understand you, yes or no. So this time it's not longitudinal, it's not vertical, it's horizontal. It's transverse contracture. So because of this transverse contracture, the stomach will be like this. It will be like this. You got my point? And this is duodenum. You got my point? So because of this contracture, it is leading to this. It is hourglass. So the contracture is longitudinal or transverse. If it is longitudinal, it is teapot. And if it is transverse, it's hourglass. I guess I tried. Say yes if you got it. Yes. Say yes. If you have doubt, please ask. Otherwise, say yes. So on the lesser curvature, we can have longitudinal ulcer, we can have transverse ulcer. The longitudinal contracture leads to teapot and the transverse contracture leads to hourglass. No one will explain you the concepts. Everyone will show you these images, the teapot image, the hourglass image. Just learn it. But don't learn. I don't say even the 19 subjects, there is hardly anything to learn. You have to understand the concept. Once you understand now, you will never forget. You will never. I have understood all these concepts. You can't believe it's 10, 12, 13 years ago when I was doing my MBBS, right? When I was in your shoes, right? So till date, I have not forget and I don't revise them frequently. But once I have understood now, I will remember till my death, right? So that is the meaning of understanding the concepts. Okay, let me go ahead. So we have done everything about the peptic ulcer. Let me tell you few important points. What is Cushing ulcer? Cushing ulcer is due to intracranial injury, right? What is curling ulcer? Curling ulcer is due to burns. We have already seen that. And we have seen the differences between duodenal ulcer and gastric ulcer. I'm not revising again. Based on 9 clinical features, we can differentiate, right? So that's all about ulcer. The treatment part will be taken in pharmacology, right? You know the triple therapy for the ulcer. What is the triple therapy? The triple therapy, there are 2 regimens. The first is LCA. You give L stands for lansoprazole, C stands for clarithromycin, and A stands for amoxicillin. The doses are given. So this triple therapy is given for 2 weeks. So that is the standard regimen for ulcers. Whether gastric ulcer, whether duodenal ulcer, basically peptic ulcer. So this is the triple therapy, the most accepted regimen. The second regimen is also triple therapy. We are changing few drugs. So instead of, it is prazole now, lansoprazole, we are giving omeprazole. Same category, prazole same hai, both are prazole. Instead of lanso, we are giving omeprazole. Amoxicillin is same, here also. Only the dose is different. And third, instead of clarithromycin, we are giving metronidazole. So the drugs can be different, against it's a triple therapy, right? So we are done. So if the peptic ulcer coming in your exam for long question, you have much things to write. You have enough things to write. You can write the definition, risk factors, etiology, type, site, gross, microscopy, complication, investigation, treatment in short. So you can write, I guess, 5-6 pages on the peptic ulcer with beautiful diagrams, explanation, concepts, flowcharts. Give me a thumbs up. Come on, everyone. And if you are preparing for your competitive exam, you have already done your second prof. So all the MCQs I can guarantee you can do. All means all. Even not a single MCQ is left which is untouched. Whether it is a conceptual MCQ, whether it is a one-liner MCQ, whether it is a big clinical based scenario, you can do that also. And whether it is a IBQ, you can solve everything. You can solve that. So this should be the pattern of your study. If you are studying any topic now, study in depth so that any type of question can be dealt. I don't know whether you are preparing for NEET PG, for INICT, for FMG, for USMLE, for MRCP, whatever you are preparing. But the thing is that concepts remain same. The concept is not different for FMG student, for second prof student, for INICT student. No, the concept is same. Maybe the pattern of question may differ. If you are a FMG aspirant, maybe the question may be small, one-liner. If you are INICT preparation, doing that, so the question can be big, clinical. If you are doing NEET PG, it can be more of image-based, whatever. But the concept remains same. That is the point. So give me a thumbs up. Come on. Right. Have you got it? Instead of lansoprazole, Osama is asking, can we give pantoprazole? You can do, but standard this regimen is followed. So if you are giving pantoprazole, you have to adjust the dose, right? Standard this regimen is given by the American Society and we follow that only. But yeah, we can give any prazole. There are many prazoles. Most commonly pantoprazole can also be given, right? But these are the 2 standard regimen given in KD Tripathi book, right? So that's why I have mentioned this here. So whenever I teach you any topic now, I try to compile from all standard textbooks. Integrated way of studying. So that is the next pattern. You know, in the next, you should have integrated pattern. If you are studying pathology, it's not you should study only pathology. If I am including the clinical symptoms and complication, it will become medicine. And if I include the treatment part, it is pharmacology. So the complete patho plus medicine plus pharma, everything is covered for that topic. Same topic you cannot read 3 times in 3 different subjects. In pathology, I should explain you only etiopathogenesis of peptic ulcer. That's it. In medicine, I should explain you only the complications and clinical features. In pharma, I should explain you only treatment. But if you compile all, it's a complete topic. That is the meaning of integration. You got my point? Anyways, So tell me if you have any doubt. Yes, so the peptic ulcer portion is done. You want to revise or it's done? I guess it's done. It's done. So still, if you have any doubt, please don't hesitate to ask on my contact number. It's 9833032948, right? You can connect me either on WhatsApp or Telegram. Don't call, but leave a message. A text message will work. The doubt related to your subject, the patho, pharma, micro, medicine, PSM. I teach all these 5 subjects, and soon, on huge demand throughout the country, I'm going to launch free PSM series also on YouTube only. So daily we will be having 2 lectures. One lecture will be of patho, pharma, micro. One of them, like we are taking daily every day at the 9 a.m. Today it was 9:30, but every day it will be 9 a.m. And PSM we will decide some other time, I guess in the evening, and in the PSM we can do that, right? So we will be having 2 lectures daily. So PSM also I am going to launch. So if you are a second prof student, you can ask your seniors and all to attend that, right? I will share the links with you. And if you have any doubt in any of these subjects, you are free to ask me on this contact number. So thank you very much. If you like the lecture, don't forget to click on the like button before leaving. Please share this link on your batch group. I request you to share the links of my YouTube channel or this lecture or any of your lecture of your choice on your batch groups and all the medicos you know throughout the globe. Please, it will help everyone. These are the free lectures, right? And they can help multiple students. So please help me in spreading the knowledge, right? And don't forget to click on the bell icon if you want further notification, and subscribe the YouTube channel and share the link of YouTube channel with all your friends, colleagues. Thank you. See you. Bye-bye. Study hard. Tomorrow morning again 9 a.m. with another important topic for your preparation, right? So I will add some sense in your preparation. You will appreciate that once you will clarify your exams. So see you. Bye-bye. Study hard. All the best. Stay blessed. Stay healthy, and all the best. I'm ending the session.